So Professor Lise Nigrovic is giving us a talk on the febrile infant. Okay.
So I'm a pediatrician, and then I did a subspecialty training in emergency medicine. And I understand that here in Italy, although people practice in the emergency department, it's not yet a recognized subspecialty. Hopefully, it will become a recognized subspecialty, and I know many of you may have interest in practicing in that setting. Just to get to know the group, how many people here are students? Great, and that is broad and is excellent. And then in training, residents? Wonderful. And then is there a fellows? Is that a advanced training? No. How about faculty? Yeah, your residents for the whole. And then the faculty in the front here. Perfect. Well, thank you for coming. I know you come from a broad group of experience. We're going to focus on the febrile infant. I'm happy to take questions as we go, but we'll take people through the management of this common condition. In terms of disclosures, among my research funding, I have some research funding from a company, Pfizer. It's related to Lyme disease, so it won't impact the talk that we're having today. Okay, in the next 40 minutes or so, we're going to talk about the approach to the febrile infant. We'll hit upon some of the changes in the epidemiology, bacterial epidemiology over the last few decades, and then talk about clinical prediction rules that help us risk stratify, particularly around bacterial infections, as well as serious viral infections like herpes. We'll talk about viral co-infections and whether that should impact our management of the febrile infant. And to do that, we have a brief introduction, but then I have 6 case studies that will take us through some key decision points in the management of a febrile infant. And if we run over, we'll just do, not all of the cases. So please feel free to ask questions, and we'll just pause when we need to take a break. As a matter of background, fever is a really common reason for sort of emergent or urgent evaluation in children. If you look at emergency department visits overall, about 1/3 of them are due to fever of some sort across the ages for children. Infants are a unique group because they have increased susceptibility to infection. They're not old enough to have received a lot of vaccinations, and their own immune system is not as developed. And so they're more susceptible to the serious infections that we worry about. However, most febrile infants will have a viral infection, not a bacterial infection. And so the goal for a clinician is the challenge of identifying those infants at highest risk for having a serious infection, but without over-testing and treating those at low risk. So the proverbial needle in a haystack. So you don't want to do too much to infants that are at low risk, but you don't want to miss those serious infections that have consequences. So what's the general approach? When you see a child of any sort, the first assessment, are they ill? And it's sort of easy if they're ill. You know what to do. They need exhaustive evaluation. They need aggressive treatment. They probably need hospitalization. But what if they're not ill? They're well appearing, but they're febrile. The next is to do a comprehensive physical examination and history to look for an identifiable source. A mastitis in an infant, infection around the belly button, an omphallitis, an otitis media. And if you identify something on your examination, in a way that's easy too. You know what treatment is indicated. So if it's a minor, if it's ear infection, you might be able to do oral antibiotics and send them home. If it's a moderate or severe infection, they need more comprehensive evaluation and potentially hospitalization or parenteral antibiotics. The challenge, and really what we're focusing on for this next time together, is those that are well appearing, have no source on examination. And the challenge is, how much testing should I do and how much empiric treatment? So in that group, what you're worried about is either serious bacterial infection or invasive bacterial infection. And the term serious bacterial infection refers to the combination of bacteremia, bacterial meningitis, and urinary tract infection. And of the serious bacterial infections, by far and away the most common is the urinary tract infection, but also the least serious. And then a subset of serious bacterial infections are invasive bacterial infections. And these are the ones we really don't want to miss, the bloodstream infections and the bacterial meningitis.
And so when we're thinking about risk stratifying, we want to make sure we don't misclassify an infant with an invasive bacterial infection. What about clinical judgment? You're all gaining experience treating young infants. I have spent my career seeing infants. Can I tell when I look at an infant who's sick and who isn't? Unfortunately, no. And in this study, there was about 3,000 infants who were prospectively assessed, and the clinicians who were caring for them, who were experienced attending physicians, were asked to do two things. They said at the time of initial evaluation, assign something called the Yale Observation Score, which is a structured observational score of how sick the infants look. And the range is between 6 and 30. And 6 is well appearing and 30 is more ill appearing. And in addition, they were asked to say, what do you think the chances that this infant in front of you has a bacterial infection in the categories that are shown here? And the results of this study are shown here. And so this is an ROC curve where you plot 1 minus the specificity minus the sensitivity for the diagnostic test of the Yale Observation Score or clinical suspicion. And if you have a line between the 0 and the bottom left and the upper right, that's a test with no discriminative ability. So it's like flipping a coin. And unfortunately, the clinical observation scores here, the Yale Observation Score and the clinical suspicion, are almost no better than chance alone. So experienced clinicians looking at a young infant, they can't tell who has a bacterial infection reliably. And so that is the heart of the challenge and why we do testing to screen for those tests. So in the absence of clinical judgment, what do you do? Historically, there were 3 rules that were used commonly. They're all American rules. They're named for the cities where they were developed, and they were all developed with single center data, and that's why they're sort of a single name. I'm not going to go through these details. They're not in common use now, but up to maybe 5 to 10 years ago, this guided the management of the febrile infant. They all look at slightly different ages of infants. They all use a combination of white blood cell, urine testing, sometimes blood or stool testing in addition. But the goal of all of these risk stratifying tools was to identify a low risk group who may not need to be hospitalized. For the Philadelphia and Rochester, the low risk infants went home without antibiotics, and in the Boston criteria, they went home with antibiotics. But overall, the goal was to not hospitalize as many infants. But things have changed, and some of the changes are due to the changes in the epidemiology of bacterial infections. So bacterial conjugate vaccines are now widespread, and they've really changed the bacterial epidemiology. So conjugating the bacterial polysaccharide to a protein carrier allows them to be immunogenic in the youngest infants. And so Haemophilus influenza type B infection used to be a deadly infection back in the 80s, but it's essentially disappeared for most of us in the room practicing in the current era. But the strep pneumonia vaccine, which first came out in 2000, and every few years there's a new advanced vaccine that comes out, the most recent PCV20, which came out in 2021, which covers 20 different serotypes of pneumococcus, has changed the epidemiology of bacterial infection. But those of you that know about childhood immunization schedules, it's given to 2 months, 4 months, 6-month-olds. We're talking about the febrile infant, the 0 to 60-day-old infant. And so you might think, well, what impact does that have on the infant who hasn't yet received the vaccines? And importantly, even though young infants don't get the vaccine, they're still protected against the infection because of herd immunity, because the other children in their lives around them aren't carrying the strep pneumo in their posterior pharynx. And so this study, which is now old, but shows the important decline in invasive pneumococcal disease that we see in the infants even before they themselves have received the vaccine. So having their siblings, the other children they're exposed to, is an important public health perspective. The second major change, we had a lovely introduction from the head of obstetrics, but the screening of women for group B strep infection and the routine antibiotic prophylaxis of those that are positive have had a positive effect on the incidence of group B strep infection that we see in the youngest infants. So what are we seeing now? This is a cross-sectional look at the epidemiology of bacteremia in the youngest infants. And gram negatives are now much more common than they used to be. So E. coli and other gram negatives are almost half of the bacterial infections we now see in infants. We do still see some group B strep and some Staph aureus, but listeria and strep pneumo, which used to be common considerations, are really very rare infections in this age group. pause for any questions. Well, hopefully the case will help bring through. So this, just starting, how do you approach a febrile infant? And these are very simple cases, but they highlight different decision points in the management of febrile infants. So our first case is a 2-week-old with a rectal temperature of 38.1. Temperatures are typically taken rectally in young infants because they're the most accurate. And on your examination, they're well appearing. You do a complete examination and there's no focus of infection. And so in this age group, what tests would you order routinely? And does this infant need to be hospitalized, or are they going to be safe to be discharged? Now, there's a lot of variability in the approach to the febrile infant, but in this age group, there's relative consensus. And so I'll share the American Academy of Pediatrics febrile infant pathway. I don't think there's a national or international guideline, but this pathway is probably it's a consensus statement of North American pediatricians. And the reference there, it's in published in 2021. It's free online, and it takes you through pathways for infants from 8 days up to 60 days of age. But just to start with, so in the 2nd to 3rd month of life, if they're well appearing and febrile, the routine recommendation is to get blood, urine, and spinal fluid routinely, regardless. And then supplemental inflammatory markers as you desire. You then assess the risk of HSV, and we'll come back to that with one of our other cases based on maternal history and examination. If the child's at high risk for HSV, it's important to test the youngest infants because that could be a deadly but uncommon infection. And but if they're not by history, you would just do the blood, urine, and spinal fluid testing. Everyone is treated with antibiotics and hospitalized for 1 to 2 days until the cultures come back. And so in this youngest infant, you don't use much clinical judgment. You just do the testing and you treat empirically because the risk of bacterial infection is high enough, and our clinical judgment isn't good at sorting out which infants should get this testing versus not testing. So that's what happened to our child. They were empirically tested and they were assessed for HSV risk factors, and we'll come back to what those factors might be, but they're hospitalized regardless of the results of those tests. They're treated commonly with a long-acting 3rd-generation cephalosporin like ceftriaxone or cefotaxime as per local practice, and their cultures are watched and they're monitored clinically. They should stay for between 36 to 48 hours while those cultures are being evaluated, but then they can be sent home. All right, we'll move on to our second case, a slightly older child. So the first month of life is pretty routine, first 3 to 4 weeks of life. But as you get into the 2nd month of life, there's more variability in practice and more evidence to help guide us, new emerging evidence and new guidelines. So this is a 5-week-old, so not in the 1st month of life, who's also febrile to 38.1 with no focus of infection on examination and well appearing. So you do blood and urine testing, which would be commonly recommended. And we have here a white count of 10,000 with an ANC of 3,500, a negative urine analysis, meaning no pyuria in the urine, procalcitonin, which is a newer inflammatory marker. And you can tell me whether that's routinely available here or not, but that's a normal level on the procalcitonin test, and a CRP, which is mildly elevated, but not extremely elevated. So the question in this infant is whether you should get a lumbar puncture, and that's where some of the newer guidelines come into play. So the first guideline that came out is from the Spaniards. Santi Montego is a pediatric emergency physician from Bilbao, and he led an effort of, I think, about 20 Spanish emergency departments. And he proposed one of the first newer clinical prediction rules, replacing those US-based city rules that I described. And so he called this rule step by step. And so the rule, it was derived from a retrospective cohort of febrile infants using a combination of statistical methods and clinical judgment, what they knew that would be assessed. And so first branch point is well appearing. And if you're not well appearing, that's a high risk infant regardless of the results of the tests. The second was age. And so if you were less than 21 days of age, you went into a high risk group. So that's the infants that are going to get comprehensive testing regardless of the rest of the tests. The second, or the third risk factor was the urine. So if you had a positive urine analysis, that puts you in a high risk group, makes the risk of UTI higher. But if all of those were negative, that's the infants where they're suggesting to get blood tests. So by this pathway, if you are greater than 21 days of age and you have a negative urine analysis, you might not even need blood testing to evaluate the febrile infant. But if you have any of those factors, you would go on to have blood testing, which would include white blood cell count, blood culture, as well as inflammatory markers, procalcitonin and CRP. And so if your procalcitonin is high, that's a high-risk infant, and they should be considered for further testing, including lumbar puncture. If your CRP is high or your ANC is high, that's an intermediate risk group. And I'm sorry, so if your PCT is less than 0.5 and your CRP is high or your ANC is high, then you're intermediate risk. If your procalcitonin is low and the CRP and ANC are normal, you're in a low risk group, a group of infants that might be able to go home without any antibiotics or further testing. How well did this rule perform? They did a prospective study of 2,000 infants, again done in Spain, and the rule performed fairly well, sensitivity of 92% and specificity of 45%. The specificity of these rules are always modest because they're designed to find the high-risk infant. Sensitivity of 92% is okay. That means 8% of those with serious bacterial infections are not identified by the rule, but the negative predictive value is quite high. That is, if you have an infant, you apply the rule and they fall in the low risk group, the risk of having a serious bacterial infection is about 7 in 1,000, 0.7%. So the rule performed quite well. The second newer rule was put together by the Pediatric Emergency Care Applied Research Network, which was referred to as PCARN, which is a federally funded research network of U.S. emergency departments. And there's 18 that collaborated for this study. And they did 2 cohorts of febrile infants with the dates here. And the rule was derived from the first, about 900 in the derivation cohort and a similar number in the validation cohort. And then they had a second prospective study, which is an independent validation, which I'll show the results. And they were enrolling infants less than 60 days of age who had a temperature greater than 38 degrees, who were having a blood culture obtained in the emergency department. And the goal was to identify those infants with a serious bacterial infection. So invasive bacterial infection plus urinary tract infection. So here's the rule that was derived. So the first factor in the decision rule was the urine analysis. So if it was positive, you went into the high risk group. If it was negative, the next decision point was the ANC. And the point that was derived in the rule was an ANC of greater than 4,000. If you had an ANC of greater than 4,000, high risk. If you had an ANC of less than 4,000, then it's the PCT. And in the derivation, they looked at a cut point of 1.71 for the PCT, the inflammatory marker. And again, higher than 1.71, you're high risk, and lower, it was low risk. How did that rule perform? So in the validation, concurrent validation sample, the rule did pretty well. Its sensitivity was 97%, specificity of 60%, and a high negative predictive value of 99.6%, which is functionally the important, because if you were to implement this rule, again, the risk of having a serious bacterial infection in the low risk group is 0.4%. The authors then modified the rule slightly to be more sensitive. So that procalcitonin cut point was pretty high, 1.7. And so post hoc, they modified the rule to be a positive urine analysis, an ANC of greater than 4,000, or procalcitonin greater than 0.5. And that rule has been validated in that second cohort of studies. And so looking at the performance for the SBI in that prospective cohort, the performance is pretty similar. Again, a very high negative predictive value. Now, you may argue, if you miss a urinary tract infection, that's far less serious than missing an invasive bacterial infection. And so here's the performance for looking at invasive bacterial infection, and slightly less sensitive. So they did miss a couple cases of bacteremia in this group, but again, a very good negative predictive value. There's been an external validation of the study done in England with 30 emergency departments in the Peruki network, which is a collaboration of emergency departments in England. And they enrolled 2,000 children with a goal of validating both the step-by-step and the PCARN rules. Unfortunately, procalcitonin wasn't routinely available for all of those infants. And so they were only able to look at the performance of the rule in the 442 that had the procalcitonin. So it was limited in that regard. But they applied the Pecan rule and the step-by-step rule to those infants. And as you'll see here, they both performed well and they both performed similarly. Again, limited by the sample size and the number of infants with invasive bacterial infections. So importantly, these are both two validated rules that seem to perform very well. They're very similar, and so they both can be applied in clinical practice. So what happened with this infant? Remember, this was the 5-week-old with the fever who had an ANC of 3,000, a procalcitonin of 0.1, and a normal CRP. So we could apply both the step-by-step and the Pecan rules, and both rules classified this infant as being low risk. So the guidance is that no lumbar puncture would be required. And again, clinical decision rules are meant to assist decision-making, not replace decision-making. So the infant in front of you may have characteristics that make you feel like a lumbar puncture is needed above and beyond the decision rules. But we often don't have factors that can really guide that decision-making. So these rules would help us say, maybe we don't need to do it in this case. In fact, this infant may not need antibiotics at all, and they could be discharged home with careful monitoring. It is important that a clinician sees them or is able to reach them in a short time frame, particularly if those cultures return positive. And in this case, the cultures were negative, so the predictive rule worked perfectly in this case, and they did not have a bacterial infection. Okay, next case. Similar child, 5-week-old with a rectal temperature of 38.1. This child is also well appearing with no focus on examination. So you start with your blood and your urine testing. So your white blood cell count is higher at 16,000 with a high ANC of 9,000. The urine is negative, but the procalcitonin is 0.6. So if you were to apply either the step-by-step rule or the Pecan rule, that child's not low risk. So at that point in time, many would go on to perform the lumbar puncture. So here we see the results of the lumbar puncture. There are 20 white cells and 20,000 red cells with a normal glucose and protein, and the gram stain did not show any organisms. So now you're challenged. So 20 white cells in the spinal fluid is not normal, but it's a bloody tap, right? It's a traumatic lumbar puncture. And so the challenge is how to interpret those results. Is that a high risk? Should we be worried about bacterial meningitis or meningitis in this child, or can we correct for the presence of the red cells? So the lumbar puncture is a challenging procedure. I think we do fewer and fewer of them as time goes on, so we probably have less skill and experience as pediatricians in doing this performance. And the success rate is often not high. And so a successful LP is one that you get spinal fluid and it's not traumatic, so we can interpret the results. So this child had a successful LP because we got spinal fluid, but we had 20,000 red blood cells. And so it's hard to interpret. Of first attempts of lumbar punctures, depending on the study, only 45 to 60% of them are successful. So this is a common problem, to either not get any fluid at all or to not get fluid that doesn't have blood in it. And overall, so if you allow all the attempts, only 70 to 85% of lumbar punctures are successful. So something important to remember when you embark on the procedure is that you might end up not being successful in the end, even in experienced hands. Things that reduce the rates of traumatic lumbar puncture procedurally is actually local anesthesia, even in the youngest infants. Applying a topical anesthetic or injectable anesthetic has actually been demonstrated in multiple studies to reduce the rate of traumatic lumbar punctures. And then additionally, in young infants, if you introduce a lumbar puncture needle and then remove the stylet as you advance once you're through the skin, that's been associated with reduced traumatic lumbar puncture rates. It's been termed the Cincinnati technique, probably not here in Italy though. Okay, what do you do if you get a traumatic lumbar puncture? We had 20 white cells and 20,000 red blood cells. And so the question is, how do you interpret those results? Sometimes people say, I'm not going to even bother to correct or interpret. I'm just going to say there's 20 white cells and that's not normal. And the presence of a traumatic lumbar puncture leads to increased hospitalization and more antibiotics. But if you want to look at trying to correct, one of my colleagues has done some work looking at those correction formulas. And so the ratio of CSF RBCs to CSF white blood cells in a child without meningitis is approximately 877 to 1. So you can correct at about 1,000 to 1 to make it mathematically easier to do. So what does that mean? So we had 20,000 red blood cells in our spinal tap. You would expect to see an extra 20 white blood cells. So those 20 white blood cells we're seeing are probably attributed to the fact that the blood was introduced at the time of the procedure, not because there's infection in the spinal space. So back to our child. So we corrected our CSF white blood cell for interpretation, and we're not worried that that child has meningitis. And so we could decide just to be careful, since you have a spinal fluid culture and a blood culture and a urine culture, to give a dose of ceftriaxone. Again, a preferred antibiotic because it lasts in the system for a long time. But that child can go home with careful recheck and monitoring of the cultures and further treatment based on the results of those tests. Okay, on to our fourth case. So again, very similar case, maybe a slightly higher temperature, child's otherwise well without a focal source. So you start based on your guidelines with blood and urine testing, looking for the most common. So the peripheral white cell count is 12,000 and the ANC is borderline at 4,000. But this child comes back with a positive urine analysis, so 20 white blood cells. So you're suspecting a urinary tract infection. The procalcitonin is reassuring. And so now the question is, should you perform a lumbar puncture? Again, how does the presence of pyuria affect the risk of having CSF pleocytosis? So the first study to really look at this in a large way was a multi-center study of 1,190 febrile infants who had a urinary tract infection. And this was done, it's an old reference, and it is important because every infant that had a urinary tract infection that was 0 to 60 days of age routinely had a lumbar puncture. So they had a urinary tract infection, but they also had a lumbar puncture. And so they examined the results of those lumbar punctures in the infants. And so 82% of them had normal lumbar puncture results, but 18% had a CSF white cell count of more than 10 after correcting for traumatic lumbar punctures. So of infants with a urinary tract infection who have a lumbar puncture performed, which in this era was routine, 18% of them have a pleocytosis. And so this led to a practice where infants that had urinary tract infections routinely all had spinal taps as well in order to identify this. Although the vast majority of these pleocytoses were sterile and perhaps reactive to the urinary tract infection itself. The bladder sits fairly close to the spinal space, and that pleocytosis may be related to the urinary tract infection, not to a primary central nervous system infection. This has now been looked at in many studies. So this is a meta-analysis combining the risk of what we care about, which is a bacterial infection in the spinal space in infants with urinary tract infections. So this is approximately 15 studies. The numbers of patients included in each of the studies are here. One of the larger ones is the Schnattauer study, which I just referenced. But very few of those infants, even if those infants had pleocytosis, had bacterial meningitis, which is what we care about. And the prevalence of bacterial meningitis in the aggregate of all these studies was 0.25%, so very low. So maybe this isn't something we need to worry about as much as we had in the past. So urinary tract infection alone may not be enough to require a lumbar puncture. The most recent study looking at this confirms that suspicion. So this was a prospective study of infants undergoing evaluation for bacteremia. And so they looked at infants that either had a positive urine analysis versus a negative urine analysis. And they looked at the risk of bacteremia between the two groups. And those that had a positive urine analysis were more likely to have bacteremia. That was most commonly E. coli. So they'd have E. coli in their urine and in their blood. And under that, it was stratified by the two age groups, first month of life and second month of life. But what we're really worried about is bacterial meningitis, which is rare in infants of all ages. And if you look at the risk of bacterial meningitis in those with a positive urine analysis, it was 0.4%. In those with a negative, it was 0.6%. So there was no difference between the groups, and the overall risk was quite low. And so taken together with the meta-analysis, we've shown, I think, the concern about concomitant bacterial meningitis with UTI is quite low. And so routine lumbar puncture just for the presence of suspected UTI is probably not needed. So this child didn't have a lumbar puncture based on the newest evidence. They were treated for their urinary tract infection, which can be done with oral antibiotics. Cephalexin is our first-line antibiotic, and that can be given orally with close follow-up. So they can be sent home with clinical recheck. They grew the most common pathogen, which is E. coli, and their blood culture did not grow the same pathogen. Infants with UTIs often need more subsequent evaluation for risk factors for urinary tract infections, which can include renal ultrasounds and VCUGs, which we won't get into here. Okay, next case, slightly younger infant with a rectal temperature of 38.2. Well appearing, no focus of infection on examination. Now we said infants in the second and third month of life are going to have a full sepsis evaluation, blood, urine testing without really further thought. So here are the results here. And we do have a positive spinal tap for white blood cells. And we can't excuse away all those white blood cells by the presence of red blood cells, but a normal glucose and protein. So the next question here is, do we test and treat for HSV infection? And so, infants in this age group are going to be hospitalized. They're going to be empirically given antibiotics for 36 to 48 hours, but not all of them are tested and treated for HSV infection. HSV is very uncommon. It depends a little bit on the population that you're studying and the underlying prevalence in the childbearing women in the population, because the infants, of course, get it by vertical transmission from their moms. In this study, we actually collected data from 26,000 infants that were undergoing spinal fluid testing in the first 2 months of life. And what we were looking at is the prevalence of HSV infection by week of life. The important thing is it's low in all age groups. So the x-axis is the prevalence of HSV disease, and the very highest was 2%, below 2%, and in most age groups it was well below 1%. But the highest risk of HSV infection is in the second month of life, and it really falls off, and the risk is quite negligible by the time you get to the second month of life. Overall prevalence, 0 to 60-day-olds in infants undergoing lumbar puncture evaluation was 0.42%. Now the question is, how many infants do you need to test and treat in order to not miss one case? And so in the first month of life, you need to test and empirically treat 142 infants to not miss one case. And in the second month of life, it's 556 infants. So this is a very rare disease, even less common than the invasive bacterial infections that we started with. So that makes it challenging for clinicians. You don't want to miss this serious infection, but it's quite uncommon. Because it's uncommon, there's a lot of variability in testing and treatment. This is what's called a heat map, where the colors are sort of the percent of from a cool yellow up to a hot red. And on the x-axis here, we have hospitals. So in that study of 26,000 infants, we looked at 22 hospitals, and we looked at how they clustered by their prevalence of testing, prevalence of empiric acyclovir, and then the number of cases. And so there are some low-risk hospitals which had low testing and low treatment rates, and some high-risk hospitals that had higher testing, treatment, and disease rates. But in the middle, there's a lot of mix. So because we don't have good guidelines, the clinical practice varies. We use this cohort to develop a clinical prediction tool for factors that were associated with HSV infection. So I'll just read them here. So younger age, the presence of a seizure, ill appearance, abnormal triage temperature, presence of a rash, thrombocytopenia, CSF pleocytosis, and prematurity. So thinking back to our case, our infant was 11 days old. They had an abnormal triage temperature, and that could be either high or low for HSV infection, but our infant was febrile. And this infant had a CSF pleocytosis, 50 white cells in the spinal fluid. So taken together, 3 risk factors. So this infant probably isn't at low risk and probably should have a empiric test, which is a PCR test, which can be done from the spinal fluid or the blood, and an empiric treatment until those tests come back. And I don't know how long your tests take to come back here. In my clinical setting, they can be back certainly within a day, and so that can guide further management. Sometimes if they have to be sent out, there can be further delays, several days to get those results back. So what happened? We would do empiric antibiotics, ampicillin and gentamicin in the youngest infants, or per your local guidelines, with the addition of acyclovir. Fortunately, the child was admitted, but their tests came back negative. So the HSV test came back, and again, depending on how long that test takes, the acyclovir would be stopped at that point in time. And also the blood cultures and the urine cultures and the spinal fluid are negative. So the child spent 2 days in the hospital, had pretty comprehensive treatment, and their tests were negative. But the risks of the infections that we were evaluating them for are high enough that sort of empiric treatment is the suggested guideline. All right, last case, and this one I'm sure you've seen. So a 7-week-old and older infant with a fever to 38.5. Parents have COVID, right? Just coming out of, or maybe they have flu. But the child is well appearing with maybe some clear nasal discharge, but no focal bacterial infection on examination. So because of the age and the height of the fever, you get blood testing and urine testing. Procalcitonin is normal, so you feel reassured. Now the question, and you test the infant for COVID, and the infant is positive as well. Does that change anything? Does that increase the risk of bacterial infection? Without the COVID infection, this child is low risk by the clinical prediction rules that I presented. But does the presence of COVID change anything in terms of your management? We have somewhat limited data, but probably the largest study was published a few years ago that came out of a quality improvement effort that were carried on through the COVID pandemic, led by Paul Aronson, who's at Yale, a peds emergency physician. So he looked at 106 centers enrolling through the COVID time, and they looked at febrile infants 80 days to 60 days old who had a COVID test. And so they ended up enrolling 14,000 infants and collecting their data. And so 3,700 had COVID. And then below that is the risk of the bacterial infections that we're looking at. And then they had 10,000, the larger group, that did not have COVID. They were COVID negative. And so if you look here, the rates of UTI, bacteremia without meningitis, bacterial meningitis, or any of the above were lower in those with SARS-CoV-2 infection documented versus those that were negative. And so just another supporting thing, in those infants with recognizable viral infections with positive tests, the risk of having a concomitant bacterial infection was probably lower rather than higher. So we can feel good about outpatient supportive care management. So we have a low risk by the step-by-step rule and the PCARN rule. We have a positive COVID test. You could consider a chest x-ray, because one of the things we do worry about in young infants with COVID is concomitant pneumonia, and that would change our management. But this child had a chest x-ray which showed no pneumonia, and clinical signs and symptoms were reassuring from a respiratory standpoint. So again, no antibiotics, and they went home. Daily rechecks, and whether that's in person or by telemedicine. Often with COVID infection, it can be challenging to get them into a routine clinical practice where they don't necessarily want to bring in sick infants. And so remote visits have, at least in our setting, become a common way that those infants are reevaluated. And the blood and urine cultures that you did obtain returned negative. All right, a rapid overview of the approach to several scenarios in the management of clinical infants. But the fever management strategies vary by age. We talked about a very narrow range, 0 to 60 days old, but that first month of life is quite different than the second month of life, where we feel more comfortable doing less testing and less antibiotics. The predictive rules that I present are both really good, the step-by-step and the PCARN febrile infant. There's slightly more data behind the PCARN febrile infant, but the rules are quite similar. And so knowing what inflammatory markers you have available in your clinical setting and applying either of them are really good strategizing for risk stratifying. If you do viral testing and you have a positive viral test, that probably reduces the risk of bacterial infection. So that can be additive information in addition to these risk tools. HSV is an important infection to remember because it can be quite deadly when present. And so in that first month of life, you want to think about HSV infection, assess the risk by history and laboratory evaluation. And infants that have any of the risk factors probably deserve empiric testing and treatment until those tests come back. Thank you.